case that I was involved in many years ago during my training as in pediatric neurology. So this is a case of an 11-year-old girl at the time. She has a background history of this label of dystonic dyskinetic cerebral palsy, and that was due to neonatal hypoxic ischemic encephalopathy. She's known to have global developmental impairment. She's wheelchair bound. She also has a degree of gastroesophageal reflux, as many of these children, as you know, have. She also has a history of epileptic seizures, and those were well controlled on levetiracetam. So she was brought by her parents to the emergency department, complaining of fever for the last 1 week. And then the parents were quite concerned that over the last 1 or 2 days, she's been quite unsettled, she's been quite upset, and she's been quite agitated for 1 day. And let's not forget that this is a child who has global developmental delay. She cannot speak for herself. Obviously, she's nonverbal, and it's very difficult to get any history from her. So we're just mainly relying on the parents to tell us what they think is wrong with their daughter. So she was seen by one of the emergency department doctors, and he did a very nice assessment. As you can see there, I just literally copied and pasted his assessment. He talked about the airway, and he said airway was patent. Breathing, he said she was distressed. She was a little bit tachypnic, as you can see there. She needed oxygen to maintain her SATs above 100, well, at 100% saturations. Her heart rate was 160. Her capillary fill time was 2 seconds. Her blood pressure was on the lower side. Her feet were cold. She was agitated. They checked her blood sugar. It was 7.5 millimole per liter, which was okay-ish. But she was febrile at 39.1 centigrades. They looked at her abdomen. They felt that her abdomen was fine. They looked at her ear, nose, and throat, and they couldn't find anything there. So the impression by the emergency department doctor was that this is a pyrexic child who is shocked. They gave her fluid bolus. Then they started her on IV maintenance, and because of this history of pyrexia, they started her on cefotaxime, and they said to keep her nil by mouth. They performed an abdominal X-ray, which was normal, as well as a chest X-ray. Okay. So then she was shifted. Then when she was in the emergency department, she had some blood tests, and just in the interest of time, as you can see there, she has leukocytosis with neutrophilia. Her CRP was normal. Her urea was up a little bit. Her liver enzymes were also elevated. And then somebody, for no obvious reason, when I looked at the notes, checked her CK, which is the creatine kinase. Okay, and that came back quite elevated at more than 11,000, as you can see there. Okay, but interestingly, no one seemed to have made any notice or any comment about this CK. So she was then shifted to the ward, and then she was seen by the consultant pediatrician on call, who again just wrote in her file that she looked unsettled. There was no focus of infection. They said this is probably pyrexia of unknown origin. Continue and will review by the night team. So she was handed over to the night team. They came after 9 o'clock in the evening. They noted that she was pyrexial with increased heart rate, respiratory rate. Her saturations were borderline. And they also wrote that she was flailing all her forelimbs. And there was some blood coming from the gingival margins and tongue. And then they added metronidazole. Now, okay, you may agree or disagree with many of these things, but I'm just telling you exactly what was happening with this patient. Okay. Again, they reviewed her after 2 o'clock in the morning. Again, the nurses told the doctors that, oh, she was thrashing in bed with jerking movements. And then somebody said, oh, this might be a seizure. Let's give her some buccal midazolam. which obviously settled her because that's what midazolam does anyway. She was still hot despite antibiotic measures. They kept the windows open. They were giving her paracetamol, ibuprofen, you name it. Okay. So then they ordered some blood tests, and the blood test came back just before 6 o'clock in the morning. And her CK this time round had shot up to more than 93,000. AST and ALT also continued to rise, but then her temperature was settling. And then the nighttime doctors decided that they needed to monitor her urine output. And then they asked the nurses to pass a catheter, urinary catheter, which took them several attempts to successfully insert the catheter. You can imagine the amount of distress and pain that this girl went through because of those attempts at inserting the catheter. And this is just a graph to show you the trend of her AST. So this is when she got admitted just in the afternoon. And this is as baseline. And then as the time went by, her ALT was rising up. And this is also to show you the CK, which is the creatine kinase, and it just continued to rise, okay? And 9 o'clock or 9:30 in the morning, you can see that it was almost at 120,000, which is obviously phenomenally high. Okay, by the way, this case was quite interesting, and I decided to publish it, and that's why you can see it here. Anyway, the pediatricians again came, saw her at 10 o'clock in the morning. They said that she was still agitated and pyrexial. At that point, her creatine kinase was over 100,000. They spoke to us in neurology, and then we said, well, this is likely to be a case of status dystonicus. And we made our recommendation that this child needed to go to high dependency unit, PICU. We recommended that she got started on IV midazolam, and we said that this child was clearly in pain, and we said we needed to control her pain, and we even suggested that she might even need to be considered for morphine infusion, hence the need to be in PICU, and she needs to be closely monitored. Okay, then over the next few hours, days, she started to gradually improve. Then we started her on baclofen in view of the dystonia. And she was discharged to the ward from intensive care unit 4 days later, and she went home and eventfully after 10 days. So I've just presented to you a case of status dystonicus, otherwise known as dystonic stall. Okay, so this was the diagnosis of this patient, and let's just maybe spend the next slides talking about status dystonicus and how to recognize it and how to manage it. But before we do that, let's just talk about dystonia. Let's just take a step back and then start to talk about dystonia. So what is dystonia? So this is, if you like, this is the official definition of dystonia, which is defined as a movement disorder. Okay, so it's a movement disorder, first of all, and it is characterized by sustained or intermittent muscle contractions, okay, causing abnormal, often repetitive movements, postures, or both. So you have two things here. You have the abnormal repetitive movements and the postures, and you can see either or you can see both things in one patient with dystonia. And the dystonic movements are typically patterned, twisting, and they may be tremulous. And dystonia is often initiated or worsened by voluntary action and associated with overflow muscle activation. If you are sitting in the clinic with a patient with a suspected movement disorder and you think, this might be dystonia, ask them to do voluntary actions, because this may bring on the dystonia, because it's one of the features of dystonia. But in reality, dystonia is all about abnormal movements and abnormal postures, as you can see in these two videos. So on the left, these are videos of the same patient. So this is an ex-24-weeker, okay, who survived but ended up with a dystonic cerebral palsy. You can see the abnormal movements here on the video on the left, okay? You can see the striatal toe, which is one of the features that we see in dystonia. You can see the twisting, okay? And you can see the repetitive and the sustained muscle contractions. And here on the left, you can see her sitting on her mom's lap, and I can assure you that this patient does not have scoliosis. But because of her dystonia, she adopts this abnormal posture. When she goes to sleep, her spine becomes straight. So dystonia is all about two things: abnormal movements and abnormal postures, okay? And I'm sure you're very familiar with these postures that you see in a lot of the patients that they come to you. You can see the in-toeing of the feet. You can see the flexion and the extension of the fingers, wrist flexion. You can see the retrocollis, which can be a feature of dystonia because of the sustained contraction of the neck muscles. You can see the opisthotronus, the back arching, and you can see all these abnormal postures in patients with dystonia. And without just spending too much time talking about the underlying pathophysiologic mechanisms leading to the abnormal movements seen in dystonia, if you think about dystonia, primarily it's a disorder of basal ganglia. And what the basal ganglia do in your body is that you have initiation of the motor signals coming from the motor cortex in your brain, and then they go down to the basal ganglia where they receive inhibitory signals so that you get a fine-tuned movement. Okay, so now I'm moving my hand there. It looks very fine because I'm making use of the inhibitory effect of the basal ganglia. But in dystonia, you get a problem of this or a dysfunction of the basal ganglia inhibitory control. And this may lead to the co-contraction of the agonist and antagonist muscles. I will show an example for that. And it's not just only about that, you get a lot of other mechanisms like abnormality of sensory input, loss of reciprocal inhibition, and changes in the cortical excitability and neuroplasticity. I mean, we can spend whole day talking about all these mechanisms, but this is just to give you a flavor of how complex the pathophysiology mechanisms involved in dystonia. So if, for example, if you look at this very simple example of an action that we always do without even thinking about, if you want to flex your elbow, two things need to happen. Your biceps, which are the agonist muscles for this specific action, they need to contract. But at the same time, the antagonist muscles, which are your elbow flexors, and in this example, your triceps, it needs to relax. Okay, so it needs to, the triceps, in other words, the triceps needs to receive inhibitory input from the basal ganglia so that it relaxes and so that you can do the muscle, the elbow flexion without any problems. The problem in dystonia is that you have both groups of muscles co-contracting at the same time, and this what leads to this kind of twisting, abnormal postures, like in this man, for example, with primary type of dystonia. You can see all his muscles sticking out, working at the same time. He's not a bodybuilder, but because of the dystonia, you can see how every muscle is working at the same time, and the simplest of motor tasks becomes very difficult for him because he doesn't have that inhibitory control from the basal ganglia. Okay. Another phenomenon that we see in association with dystonia is the dystonic tremor. And this is not to be confused with the cerebellar tumor. So this is again, a patient I used to look after with primary dystonia. You can see the dystonic tremor there, okay, which is jerky, it's irregular, It's quite variable in amplitude, and it's usually seen during sustained postures or movements. And when the patient is in complete rest, you don't usually tend to see the tremor. So if you see tremor in a patient with dystonia, that is just part of the dystonia itself. Okay, so how do we classify dystonia? And without again spending too much time on this, but just to that you're aware, there are two axes that we classify dystonia upon. The first one is based on clinical features, and the second one is based on the etiology of the dystonia. And again, very quickly, you just need to note the age of onset when the dystonia actually started. Did it start at the age of when the child, during infancy or during childhood or later on? You also need to look at the body distribution of the dystonia. Is it focal, i.e. just only focused on one part of the body, or is it all over? You need to look at other associated features, for example, if they have other types of movement disorders like myoclonus, choreoathetosis, etc., etc. When we consider the etiology, again, there is a pathway for classifying the etiology of dystonia. But in reality and in practice, the way I look at dystonia from an etiological perspective is either I'm dealing with a primary dystonia or a secondary dystonia. I like to make my life simple and easy. So if I'm dealing with a primary dystonia, it means that this child has dystonia, and if I do an MRI scan on this child, the brain MRI scan will be normal. And if I have the luxury of doing genetic testing, I'm more likely to find a genetic cause for this child's dystonia. So this is primary dystonia. On the other hand, if I'm seeing a child with dystonia, and if I do a brain MRI scan, and if the brain MRI scan is abnormal, especially showing changes in the basal ganglia, then I'm more likely to be dealing with a secondary type of dystonia. And this is by far the commonest types of dystonias that we see in our pediatric practice. And a good example is a child with kernicterus, for example, as Dr. Ali was mentioning earlier in his talk. You get deposition of the bilirubin within the basal ganglia, and you would see that in the brain MRI scan. And if I do genetic testing, unlikely to find anything because this is an acquired cause. Or sometimes in metabolic conditions, you can also get dystonia, and you do the brain MRI scan. Brain MRI scan is abnormal. Again, I would like to think of dystonia as in terms of its distribution in the body, either as generalized, meaning that it's involving the whole body, or hemi, one side of the body, segmental, at least two parts of the body, or focal, mainly involving the hand, for example. It's either isolated or combined with other types of movement disorders, as I mentioned earlier, either with myoclonus or choreoathetosis, etc., etc. And this is again an example of children with generalized dystonia. Here on the left, you see a child with primary generalized dystonia caused by genetic mutation in the DYT1. Okay, you can see the dystonia, you can see the twisting, the abnormal posturing, you can see the patterned sustained contraction movements, and it's involving the whole body, even the oromandibular region, and that's why these patients sometimes can have dysarthria, slurred speech, etc., etc. On the right here, this is a case of a child with Leishman syndrome, which I'm sure you're all very familiar with, due to abnormal urate metabolism. You can see the dystonic movements, it's patterned movements, you can see the twisting, and it's generalized. And if we do a brain MRI scan on this child, his brain MRI scan is unlikely to be normal, so it will show some changes. Another example of a child with segmental dystonia. So this is a secondary type of dystonia. So this is a child who had a thalamic tumor on the left, and that was resected by the neurosurgeons, but unfortunately he was left with an upper right upper limb dystonia. As you can see there, you can see the dystonic posturing, you can see the abnormal movements. you may even argue there is a little bit of a tremor there, which is a dystonic tremor. And mind you, this is a child who used to be right-handed, you know, and now he's really struggling with his day-to-day activities. Okay. So now let's talk about the status dystonicus, otherwise known as, referred to as dystonic crisis or the dystonic storm. And it's really a storm because it's one of the conditions that I firmly believe that is under-recognized and is under-treated. Not many pediatricians know about status dystonicus. And I think, you know, if you just come out from this presentation by just one take-home message that status dystonicus does exist and I should be looking out for it, I think I would feel happy that I did a good job. So how do we define status dystonicus? We're very obsessed with definitions and we want to define things. So one of the earlier definitions that came out back in 2007 by Mariotti et al. Is that they defined status dystonicus as a life-threatening disorder that develops in patients with both primary and secondary dystonia. Now, obviously, you know the difference between primary and secondary dystonia. And it is characterized by acute worsening of symptoms of dystonia, obviously, with generalized and severe muscle contractions. And then a few years later, the group from Ireland and London wrote a nice review on status dystonicus, and then they added to that definition about the biochemical marker for status dystonicus, which is the creatine kinase. And they said, in order for you to make such a diagnosis, which is status dystonicus, the CPK should be more than 5 times the upper limit. So for example, in our hospital, the upper limit is around 200. And if it's 5 times, so anything that is above 1,000 international unit per liter is considered to be abnormal. And within the right context, then you're more likely to be dealing with status dystonicus. Further on, another group came up with another definition, which I think is probably more inclusive. And they defined it as a movement disorder emergency. So it's an emergency. And it is characterized by severe episodes of generalized or focal hyperkinetic movement disorders that had necessitated urgent hospital admission because of life-threatening complications, regardless of the patient's neurological condition at baseline. It's a little bit wordy there, but I think, again, it's practical in the sense that you have a hyperkinetic movement disorder, which is a life-threatening emergency. So again, if I want to simplify things, now we all know about what dystonia is. And one of the things that is quite characteristic of dystonia is the twisting. And if you look at dystonia, I would usually look at dystonia at sitting at one end, and on the very far end of it, the opposite end of it, is the status dystonicus. So it's just worsening of the dystonia. So you have dystonia in which you have twisting, but then if you have a status dystonicus, then there is even more twisting. And of course, this leads to, you know, muscle contraction, and this sustained muscle contraction will lead to muscle damage. That this will lead to release of myoglobin in your blood, and that's why your CK goes up. And then the myoglobin, obviously, it needs to come out of your body, so it goes through the renal tubules, and then it may clog up your renal tubules, and then you may end up in acute renal failure. Now, despite all this, we still do not have a well definition of status dystonicus, because compare status dystonicus to status epilepticus, for example. In status epilepticus, everything is very well defined, as we'll just as I will show you. So the way I look at status dystonicus is just like the sister of Cinderella. I'm sure you're all very aware of the story of Cinderella and her sisters, and how her sisters were very mean to her, and they were, treating her really, really badly. And no one seemed to have any recognition for Cinderella. So status epilepticus is very well recognized, and everyone talks about the status epilepticus. It's very well recognized. The time is, so the definition is if you have seizures lasting more than 30 minutes, then you are in status epilepticus. And not even that, people talk about time point 1, T1 and T2, etc., etc. And not even that, there are lots and lots of algorithms to tell you how you can diagnose the status epilepticus and how you can treat it. But no one talks about the status dystonicus, which is really surprising. So to me, I think status dystonicus is still an under-recognized condition. And as I told you earlier, I think many pediatricians do not know about the status dystonicus. And because no one knows how common this condition is, no one knows the incidence of it. But I don't think it's rare. I think it's not uncommon. And again, even if you manage to diagnose it, sometimes many of these children end up being undertreated. And unfortunately, status dystonicus can kill. It can kill children. In some case series, the mortality rate was as high as 10%. So in that case series, 1 out of 10 children diagnosed with the status dystonicus actually died. So how does it look like? So for example, on this video here on the left, this is a boy with a genetic condition. And one of his problems was dystonia. So you can see him here, quite uncomfortable, quite restless, quite upset. Then all of a sudden, he goes into this stage whereby, he is contracting, co-contracting. He has this kind of banana shape, opisthotonous. He's very restless, very upset. And if you see this child in emergency department, it's not unusual for you to consider, oh, this child may be having a seizure. But no, this is not a seizure. This is a status dystonicus. If you measure his CK, his CK would be in thousands. This is another example here on the right of another girl with status dystonicus, but this looks slightly different. So this is what we would call a tonic status dystonicus, because there isn't a lot of movement, but if you feel her muscles, they're very tense, they're very contracted. And again, you can see how she's just lying in this banana shape with this back arching. And it's very distressing. It's very, very painful to be in this. Again, if you measure the CK will be in thousands. Status dystonicus can be predictable. So this is a patient who is known to have a primary dystonia, a genetic type of dystonia. And this is just a day or two before he presented acutely to the emergency department with increasing restlessness, being just his baseline dystonia is just getting worse. He can't keep still. And then he went into the true dystonic storm. And as you can see here, he's just all curled up, is very distressed, very twisty, and again, when you measure his CK will be up to the roof. So actually, you can sometimes predict status dystonicus in some of these patients. And even this has been reported, and people said there is this condition which is called pre-status, and this is a nice paper which was published quite recently, and then they said actually if you look at the group of children with dystonia, actually 10% of them can go into status dystonicus, which is quite alarming again. So just going back to my point is that it's not that rare. Okay, infections are the most common precipitant factor. In a country like Sudan, where there is high prevalence of all sorts of infections, these patients who are at baseline have dystonia, when they get an infection, they're more prone to go into status dystonicus. In about 30% of cases, intensive care unit admission is needed. And subsequent relapses are common, reaching 25% risk at 1 year. So if you have one episode of status dystonicus, then this means within the next year, there is a 25% chance that you may go into another episode of status dystonicus. So again, I would like to call this, I would like just to quote this bang factor. Unlike in status epilepticus, where all of a sudden the child goes into seizures and status epilepticus, in status dystonicus, we don't always have this bang factor. It doesn't happen just, out of the blue. There is usually some slow progression, if you like. And when I say slow, usually over days. So for example, this is a graph of a child who was stable, as you can see here in this graph. He was stable in his dystonic state. Then a trigger happened, and then he goes slowly into the dystonic storm prodrome, and then, excuse me, a couple of days later, he goes into the proper dystonic storm. He gets treated, and then very gradually, very slowly, he goes into this kind of partial recovery, which takes days and days and days. And you can see it may take up to 30 days to go back to baseline. So what are the triggers? What could trigger status dystonicus? Infection, as we've seen in about half of the cases. Drugs adjustment. And I think this is, again, an important factor. If you are making any changes, if you are introducing baclofen, or if the parents run out of medications, for example, in a case of child with trihexyphenidyl, if they run out of the medicine, then this may precipitate status dystonicus. Some of these patients may need to have surgery. A surgical procedure itself may trigger status dystonicus. Some metabolic disorders, if they have deep brain stimulation, and if that fails, then they may also go into status dystonicus. And in about 1/3 of the cases, and about 32% of the cases, there isn't usually a precipitating factor. It just happens. Again, please, when you're seeing any child in your clinic for their follow-up, and if you think that they are in pain, please just spend some time to try to figure out where this pain is coming from. Remember, most of these patients, especially the ones with secondary dystonia, they cannot talk. They are non-verbal. They cannot tell us if they are in pain, or if there is pain, where this pain is coming from. And just go through that quick mental checklist. Check, do they have headaches? Do they have any dental issues, gingivitis? Do they have any eye ulcers, any corneal ulcers? If they have gastroesophageal reflux, which can precipitate and trigger dystonia and dystonic spells. Do they have urinary tract infections, any kidney stones, any pressure sores, any fractures, any muscle spasms, all those kind of things. So just try to make that effort to identify a pain source in these patients with dystonia. Status dystonicus can lead to many problems. If a child goes into status dystonicus, what happens? So they may actually develop fever and hyperthermia because of the status dystonicus itself. And this can be quite tricky to differentiate between infection leading to fever and status dystonicus itself leading to hyperthermia. Obviously, this is very painful. It's a painful condition. It may lead to exhaustion. These children cannot sleep. Rhabdomyolysis, as we've mentioned earlier, raised CK, renal failure. They may go into dehydration, electrolyte disturbances. They may also go into bulbar dysfunction. There is risk of aspiration. They may even go into joint dislocation. I remember a child who used to dislocate her shoulder every time she went into status dystonicus, respiratory insufficiency, airway compromise, and death, as we've mentioned, in about 10% of the cases. So how do we manage these patients? Okay, so obviously you just follow your normal APLS or PALS protocol, or BLS protocol. Look at the airway, breathing, circulation. Make sure that these patients' airway is patent. Look after their breathing. Do they need to have oxygen? Many of these patients will be dehydrated, so make sure that you give them IV fluids and give them a muscle relaxant, because they have this co-contraction, as we've seen in the videos, and you need to relax their muscles. And if you give them a muscle relaxant, then you're more likely to send them to sleep, which is one of the best medicines for dystonia. Okay, so sleep is really, really important for these patients. And you need to break the cycle, because if they are in pain, then they are more likely to have muscle spasms. And muscle spasm itself is quite painful. And then they go into more muscle spasms. So you need to break this cycle, and you need to pay attention to their pain control. You need to really, really give them good analgesics, whatever you can get hold of. And one of the things is sometimes let them to sleep. Sleep, as I said, is the best medicine. Just unplug their brains, literally. Okay, give them something to sleep, and that's sometimes we give them chloral hydrate, which is a hypnotic, to get them to sleep. I'm not going to go into much details about this, but the reference is there. But this is just again to show you, how you can care for a patient in status dystonicus. Many of these patients may need to go into intensive care unit. You need to give them dystonia-specific therapy, sometimes drugs, as mentioned here, oral baclofen, tetrabenazine, if you can get hold of. Sometimes you may need to give them invasive therapy. They may need to have IV midazolam, even some anesthetic agents like propofol. And sometimes you may even need to go for surgical options like intrathecal baclofen infusion, which I know is not available in Sudan, but it's something to think about. Okay, this is a very nice guideline which is published in Developmental Medicine and Child Neurology. And if you have time, I think it's free access. Just go to the website, download it, and it's a really good read. Okay, I'm not going to go into too much details, but again, the whole idea is, you need to support them, give them good hydration, give them sedation, let them sleep, control their pain, and then look at dystonia-specific treatments such as trihexyphenidyl, haloperidol, even baclofen, benzodiazepines, gabapentin, clonidine, etc. Management of status dystonicus is not usually straightforward, can be quite challenging, because under recognition may lead to delayed management and complications, as we've discussed earlier. Lack of high quality evidence regarding the management is a problem. Access to critical care is not always readily available, especially if you're working in Sudan, for example. You don't have access to intensive care unit or HDU setting. So that can be quite difficult. Benzodiazepines and opiates, which are often required, have the potential for cardiorespiratory compromise, which means that you have to really look after these patients very vigilantly. Supportive therapies are not always available, such as dialysis, for example. Some of these patients may need dialysis. Invasive therapies such as intrathecal baclofen, deep brain stimulation are not always accessible, which has actually led some authors from London to consider using a good option, which is clonidine, and I wrote an editorial on it. As you can see, it's published in the European Journal of Pediatric Neurology. And I think you can, based on their study, you can actually use clonidine to get these kids out of intensive care unit and hopefully minimize the risk associated with the treatments. So in their study, they were giving clonidine either via enteral route, so you put an NG tube, or you could give it through the intravenous route, or even transdermal route if you have the clonidine patches. Okay, and you can give them up to 9 micrograms per kg per hour, which is quite a high dose, but based on their study, they said it's a safe option, and administration of high dose clonidine was associated with decreased use of benzodiazepines, morphine, and propofol, avoiding invasive respiratory support for quarter of the cases during their admission. So I think it's a good option if you're working in a place like Sudan or elsewhere in the world. You can think of clonidine. Okay, so just in the interest of time, I'm just going to move quickly to, this is a patient who came to our hospital some time ago. She's known to have hydranencephaly, and she has really terrible dystonia. And she used to come to us with repeated episodes of status dystonicus. As you can see there, the back arching, she's very distressed, she's in pain. And we managed her with oral clonidine, which was given 4-hourly via NG tube, as you can see there, and oral chloral hydrate, and she settled within 24 hours. And that was a good result. So again, if you have a similar case, maybe you could use a similar strategy. So just to wrap up, status dystonicus does exist, and please, please, please look out for it, because if you don't think about it, you're not going to be diagnosing it. And it can be predictable. If you see a patient in outpatient, and if the parents tell you, well, actually he's getting more restless, more in distress, there is pain somewhere, just try to be more proactive, adjust their medication to prevent them from going into status dystonicus. And treatment should be early and aggressive, as we've talked. And as I've shown you, clonidine via different routes could be helpful when access to PICU is limited. And better recognition and treatment will avoid needless suffering for these patients. And by that, I finished my presentation, and thank you very much for listening and for joining in.
Thank you very much, Mohamed. This is very excellent. As usual, we enjoyed your talk. You explained it in a very simple way. Really, we enjoyed it. So any questions? You will see the Q&A box. There is a question: in which mechanism that status dystonicus caused rhabdomyolysis?
Yeah, that's a very good question. So what happens in dystonia, if you just go back a step backwards, as I mentioned, you have the co-contraction of the agonist and antagonist muscles, because there is loss of the inhibitory control from the basal ganglia. And then what tends to happen is you have all your muscles contracting vigorously in a sustained manner all the time, as we've seen in some of the videos I've shown you. And this sustained contraction will lead to muscle breakdown, and then this will lead to release of the myoglobulin. And as a result of this muscle breakdown, your CK will actually go up. And that's why you get the hypercalcemia as well as the myoglobinuria. And if you look at the urine of these kids, the urine will be dark because of the myoglobulin. And if you leave this untreated, then these patients may go into renal failure, even sometimes requiring dialysis.
Okay, another question. What was the cause of hyperpyrexia and dystonia in the scenario? I think the scenario I've given earlier.
Oh, okay. Now, they haven't found any infectious etiology as such. And if you remember, the CRP of that patient was low, and it did remain low throughout her admission. The fever itself is probably caused by the sustained muscle contraction and increased metabolic rate of the patient. And as I mentioned in some of the slides, some of these patients may have hyperthermia, just purely because of the status dystonicus itself. Any more questions?
There are 2 or 3 more questions, Mohamed. What was the role of IVF, IV fluid, maybe in preventing AKI due to myoglobinuria?
Again, it's very simple. These patients will be dehydrated because of the increased metabolic rate, because of the fever itself, and because of the excess exercise that these patients are doing. I mean, if you think about it, it's just like running the marathon. If you run the marathon, what tends to happen? You sweat a lot, yeah? So you lose a lot of fluids. In addition to the fact that these patients, because of their status dystonicus, are unable to eat or drink. So by default, these patients will have a degree of dehydration. So you need to cater for that, give them IV fluids. And if you're giving them IV fluids, you're helping their kidneys to wash out all the myoglobulin and to prevent any accumulation of the myoglobulin. And that's why you need to give them IV fluids effectively.
An interesting question here: is there any surgical intervention to treat dystonia?
Oh, right. Okay. So that's another talk for another day. There are several, so surgical management of dystonia, we're not talking about status dystonicus. You could, so there is intrathecal baclofen, which is given via a pump. So the surgeons implant a pump inside the abdominal cavity, okay, well, underneath the abdominal skin. And then off it comes a tube or a catheter that goes into the spinal canal, and it goes into the spinal, and then it delivers the baclofen. So you put the baclofen itself inside the pump, and then the pump works 24/7, pumping the baclofen. So that might be a surgical option. Sometimes you may need to consider. This is usually for the secondary dystonias. For the primary dystonia, now people are moving more towards deep brain stimulation, whereby again you insert a generator, electrical generator here underneath the clavicle, and then off it comes two wires, and they go inside the basal ganglia, and they stimulate the basal ganglia so that the basal ganglia can send its inhibitory impulse, so that you get better control of the dystonia. So deep brain stimulation usually has a higher success rate in primary dystonias. And if you remember from my talk, I said in primary dystonia, your brain MRI scan is normal, meaning that the basal ganglia is normal and not, structurally. So there wouldn't be any problem if you put the electrode inside the basal ganglia. Other options, sometimes they may do pallidotomy, which is you just literally cauterize the pallidus, which is part of the basal ganglia. And this has been used in refractory cases of status dystonicus, for example. But now it's kind of going out of fashion, because now we have the deep brain stimulation, which has been around for the last 10, 15 years. And many, many children around the world with primary dystonia, even with secondary dystonia, have been inserted with deep brain stimulation with really good results.
Excellent, Mohammed. So what is the role of botulinum toxins in management of dystonia?
Okay, it's a very good question. Now, remember in one of the slides, and that's why it's important when you're making that clinical assessment, you need to know where is the body distribution of the dystonia. Am I dealing with a generalized dystonia, or a focal dystonia, or a segmental dystonia? If it's segmental or focal dystonia, then botulinum toxin is actually your treatment of choice, because in the case of the boy that I showed the video, who has the segmental focal dystonia in his right upper limb, if you inject certain groups of muscles, then this may improve his dystonia. But in the case of the child with generalized dystonia, where do you inject? You cannot inject the whole body. And whenever you're injecting Botox, there is a dose limit. So you cannot inject every single muscle in the body. In short, botulinum toxin is a good option, but mainly for focal and segmental dystonia, not for generalized dystonia.
Okay, another question here. What is the first and second line, treatment so far for dystonia? First and second line.
Okay, again, there is no kind of, agreed guidelines on this. It depends on your expertise. It depends on your experience. My very own practice, and you're very welcome to follow it, and you're very welcome to reject it, but this is what I do. Sometimes I use gabapentin as my first line, and I can go up to 20 milligrams per kilo per dose 3 times a day. Sometimes even higher than that. I've certainly gone up to 30 milligrams per kilo per dose 3 times a day, 40 milligrams sometimes, but I usually stay around 20 milligrams per kilo per dose 3 times a day. And then you could also, depending on your assessment, if I'm dealing with a child with cerebral palsy who have mixed dystonia and spasticity, I would probably start with baclofen rather than gabapentin, because baclofen is mainly an anti-spasticity medication. It does have anti-dystonia medication, but in my own experience, it's not the best anti-dystonia medicine out there. Then your second line, you may also wish to consider things like trihexyphenidyl, which is good for dystonia, But the problem with trihexyphenidyl, it may cause constipation, which in itself may exacerbate dystonia. And it may also cause some mental dullness and so forth. So I'm not a big fan of trihexyphenidyl, but sometimes I use it. Clonidine, you can also use it. You can use it 3 times, 4 times a day. It helps when you sleep. It's an anxiolytic, and you know, it has good anti-dystonia profile as well. So these are the common ones that we tend to use. And as we've mentioned, botulinum if I'm dealing with segmental or focal dystonia.
Mohammed, your talk creates lots of discussion, and I have seen many questions now in chat box.
Yeah, and I'm really sorry. I think I overran a little bit, so I'm happy to stay to answer questions if people wish.
We
Again, I'm
still
happy
have
to.
time. I think we have time. There is a question here concerning management of dystonia. Is it only symptomatic, and how patient uses baclofen daily, or what? I mean, talking about the use of baclofen in treatment of dystonia.
So again, baclofen, as I mentioned, it's a good option, but it's not the best. And if you are thinking of, as I said, in the case of a child with mixed dystonia, then a mixed cerebral palsy, for example, with spasticity, baclofen is definitely something to consider first. But again, obviously, you have to use it daily, and best thing is to use it 3 times a day. I've seen people using it once or twice a day, but I think it's best if you can use it 3 times a day. The problem with baclofen, if you use it, if you're committed to it, you have to tell the parents that they shouldn't stop it abruptly, because baclofen withdrawal can also cause issues and can cause problems. So you have to be careful with it. Obviously, sometimes it causes drowsiness. And in some of these patients, occasionally, especially if they have axial hypotonia. So if they're hypertonic peripherally, but if they're axially hypotonic, baclofen may exacerbate their axial hypotonia, and it may make them even weaker centrally. So you have to be, and they may end up with a head drop, that kind of picture. So you have to be careful with the use of baclofen. But generally speaking, it's a reasonable option. One of the other options which we haven't talked about is the benzodiazepines, which you can also use. So diazepam is a good option, and I know it's available in Sudan. Clonazepam, which Rivotril, is also a good option if you don't have many things to try. But with clonazepam, you have to be careful because it causes oral secretions, and many of these patients are may have swallowing difficulties. They're unable to handle their own saliva and secretions. So again, you have to be careful, but clonazepam or diazepam could also be a reasonable options.
And the last question, Muhammad, what about the use of L-DOPA in management of dystonia?
Excellent. That's a very good question. And I'm sorry, I haven't included slides about DOPA responsive dystonia, which is one of the primary dystonias. And actually which is a genetic disorder, it's a primary dystonia. They may present to you with developmental delay. Some of them may wrongly be labeled as diplegic cerebral palsy because they may have tiptoeing, those kind of things. And you do their brain MRI scan. Their brain MRI scan is completely normal. There is no perinatal history of significance. And then you give them a trial of levodopa, and then you cure them, literally, okay? Because it's DOPA responsive dystonia, something to do with the metabolic pathway of the dopamine inside the brain and how the brain handles the dopamine. And the only treatment, which is a life-changing treatment, is levodopa. In secondary dystonias, you can try levodopa, but at the end of the day, it's a trial. Some of the patients with secondary dystonia may benefit from giving them Cinemet, which is levodopa. But in some cases, you may actually worsen their dystonia. But unless you try, you wouldn't know which patient would favorably respond to L-DOPA or vice versa. But again, it's a common practice that I think people should be aware of. If you are confronted with a patient in whom you think there is primary dystonia, there is no harm of whatsoever of offering them a trial of levodopa. And my own practice is I usually give it for 4 to 6 weeks. And if it's L-DOPA, if it's DOPA responsive dystonia, which is a condition that you shouldn't actually miss, the response is dramatic, and they only need a small dose, up to 5 milligram per kilo per day. Just a very small, tiny dose will suit them. So it's always a good practice to try L-DOPA and see what happens.
Okay, thank you very much, Mohamed. Thank you very much for the excellent
Thank you
talk.
for having me.
Really, we enjoyed